Hello, I'm Dr. Maury Markman from City of Hope. And in the last segment of Minutes with Markman, I noted the past and current truly foundational role of surgical oncology within the care of patients with solid tumors. With the introduction of radiation and systemic therapy, there were now, and this happened over obviously a number of years, three major strategies available within the oncology community's armamentarium to treat malignant disease. And here we're specifically talking about majority of cancers, which are the solid tumor-based malignancies. However, it would be really stretching the terminology to label the early use of these modalities as being multidisciplinary in nature. In fact, therapy of solid tumors was principally, in some cases, almost exclusively sequential. Surgery first, except where this could not be done due to the spread of the disease locally, regionally, or metastatic, or because of an operative risk. But we're going to operate or not. Followed by radiation. Radiation might be used if you couldn't operate for local control, so used instead of surgery, or to get the edges, get the nodes. But it was after the surgery, and only if only you said you couldn't use surgery. And of course, chemotherapy was literally not thought of, even though it was available in early times, except with known metastatic disease, or if a cancer recurred, or you operated and you found it was still there. And then later, after the fact, after the surgery, after the radiation, as an adjuvant approach. It was sequential. This was not multidisciplinary. Yes, you used the different modalities, but you went from one to the next to the next. You might not have even discussed this among the specialists during the care until you got to the next modality's time. Today, however, has been a true transformation in the management of many solid tumors, where the term multidisciplinary is appropriate. Literally, diagnosis is made, perhaps even before the diagnosis is made, team comes together. It could be the surgeon, it could be the general surgeon, it could be the plastic surgeon, certainly the radiation oncologist, the medical oncologist would get together to plan an approach. The options are carefully considered at the time of initial diagnosis. From an approach to minimize the extent of surgical removal of normal tissue to preserve bodily function, for example, very prominently, limb-sparing surgery for bone sarcomas, or even the delivery of chemotherapy prior to definitive surgery, so-called the neoadjuvant approach, designed to both reduce the morbidity of surgery and to optimize the opportunity for a subsequent complete surgical resection. Further, surgeons are actually today called upon to assist the medical oncologist in the administration of anti-neoplastic drugs, such as by placing intrahepatic catheters in the management of colon cancer, metastatic to liver, or intraperitoneal chemotherapy in the management of a GYN malignancy. To give the drugs directly into the body compartment, the surgeons assist in making that possible. Now, in the final segment of Minutes with Markman on this topic, dealing with the evolution of surgery and cancer management, I want to recognize the amazing transformation in the recognized role of this modality in the effective management of known metastatic disease, and to note several relevant, unique aspects with the current use of this modality. And I thank you for your attention.